So clofarabine has been used in the past for pediatric ALL in general. And I think what we have done is the regimens called Clobufort, the many regimens from MD Anderson, they've looked at clofarabine in the preconditioning, but many of the regimens were used like a month prior, and then the toxicity is mostly neutropenia, pancytopenia that lasts for months together, and then patients are not eligible for transplant. By the time they come to transplant, they're so neutropenic that they cannot get onto the transplants. The whole concept here is clofarabine conditioning just prior to transplant, and just 3 days of rest and go to the reduced intensity regimen or haploidentical transplant after that. I think we did not see any toxicity. Main thing was capillary leak syndrome is considered a main toxicity of clofarabine, and by doing hydrocortisone pre-medication, you can ameliorate that too. So initially, we presented and published 2 cases of clofarabine, followed by like the Flu-Bu-3 TBI PTCy, and these were younger, like 38 to 40 years old patients, and they're now more than 5 years in remission, but they were very young. So our initial thought process was this regimen was good for only under 55 years old, but most of our AML patients are a median range is like 60 or 65. So how do we get those patients who are not in remission to transplant? So we thought Flu-Cy PTCy, TBI PTCy is a perfect non-myeloablative regimen. So clofarabine is used as preconditioning. You get the leukemia burden down, and then using reduced intensity conditioning, these patients can get through transplant with no issues. And that makes more and more patients eligible. So what we are trying to do is how patients, one thing we have seen is in the last couple of years, you have seen as we used to do 7+3 as our standard therapy for induction, and that has changed now to more azacitidine, venetoclax, and other targeted agents in the upfront setting. The question becomes, if these patients do not achieve remission, this is the way, if you have to do transplant and they cannot be eligible for transplant because of some of the patients are like 40-60% blast, can we get them to transplant by using this combination of preconditioning followed by Flu-Bu-2 versus Flu-Cy PTCy? And I think TBI was used more for engraftment. What we saw was when you use 400 of TBI, there was more toxicity. So this regimens have actually evolved as we did transplant, that we thought by using less TBI, you can achieve the same thing and avoid the toxicity and GvHD. But some TBI was needed for engraftment. And role of PTCy, if you saw, I think there are CTN trials, I think 1703, I think, which has given us the way of doing transplants using PTCy and avoiding tacrolimus. So I think we are moving from the way we did transplants in the past to going more reduced intensity, using post-transplant cyclophosphamide to its best ability to prevent GvHD, and then maintenance therapy to keep these patients in remission. So I think we are evolving as we go.